to just prepare her presentation. In the meantime, while she's preparing, I thought I'll just show you this last 1-minute clipping because it's important for us to see contraindications to the glutathione also. So you see this patient had we had fixed for glutathione. The problem in this case is very simple. Look at this contraindications for glutathione which you have to see. This patient was an 85-year-old lady, ladies and gentlemen. First thing, why operate an 85-year-old lady? Okay, but I said no, I will fix. Second contraindication, patient was 20/20 with aphakic glasses. Why touch 85-year-old lady? So I said no, I will fix. Third contraindication, ladies and gentlemen, in this patient was endothelial count was only 1400. I have to be mentally retarded to try to fix a glutathione in this patient, okay? But I said no, I will fix. The fourth contraindication was this patient's daughter was an eye surgeon. You see, now when I'm operating, this daughter is watching through the side port like this. Now my hand is shaking. Already it shakes. Now shaking even more.
So you can't fix that now, that she's an eye surgeon.
So now, last contraindication, my wife's mother. I tell you honestly, ladies and gentlemen, luckily things went well. Otherwise, my wife would have cut me into such small pieces, even with an electron microscope, entire Delhi could not have found a piece. So I just thought I'll just show you this last photograph and then give it to Namrata. Okay, this was my mother-in-law at the age of 70. Okay, and after the glutathione, this is her at 87. Thank you very much, ladies and gentlemen. Can we shift it to Namrata now?
Thank you, Amar, and thank you for doing this course, which we've been doing for, I think, last 4 or 5 years. And I would be talking to you about cataract surgery in corneal disorders. There are no financial or proprietary interests, and the bigger question would always be whether to do cataract surgery alone or to combine it with some kind of a procedure. So factors which determine whether it is a single stage procedure or combined procedure include the type of the opacity, the location of the corneal haze, expertise of the surgeon. You may want to do SICS if you're not well versed with phaco, availability of the donor corneas, and the visual requirement in terms of risk-benefit analysis. The intraocular lens in these cases is generally monofocal, and generally IOL master is not possible to do it. An algorithm for Fuchs dystrophy with cataract. So if there are no epithelial changes and the corneal thickness is less than 650 microns, cells are more than 1000 square millimeter, you can do phaco alone. But if it's a poor view for phacoemulsification with the central corneal thickness more than 650 microns and cells less than 800, then you always have to combine it. It is important to plan your incision because one half of the cornea should remain clear from where you will do your phaco maneuvers. And just to give example of this case, there is a haze which is present here. The incision is planned temporally here. This half of the cornea is clear from which you can do your surgery. Trypan blue staining of the anterior capsule is done. As you come down into this area of haze, you have to go in one go. Don't leave the edge of the rexus there, because if you leave it at there, then you can't pick it up again. This is followed by nuclear emulsification, irrigation, aspiration, and intraocular lens implantation. This is yet another case of corneal opacity with cataract, fellow eye lost to post-keratoplasty infection. So patient didn't want a keratoplasty here, and it's a hard cataract with optical iridectomy. Again, trypan blue staining of the dye is done. As you come underneath that thing, you have to go beneath the corneal haze, pull it down a little bit to see the edge. Make the rexus also a little bit eccentric, because this is the area where you are going to be working. Again, when you do the crater and chop, the crater becomes a little eccentric because one has to chop the area of visualization. Again, don't forget to put the retroillumination on, because as the retroillumination is on and you do phaco in situ, which means that you chop and you eat, you chop and you eat, The red glow gets better and better, which allows you to see these grayish or whitish fragments much better. And sometimes you may have to lollipop these fragments from the area of the haze into your phaco probe or into your irrigation aspiration probe, and foldable intraocular lens is then implanted, which is done in the bag, again looking at the edge of the rexus here. So these cases, this was in fact a case not referred for corneal transplantation, only we had planned a pupilloplasty, but just as we did pupilloplasty with the vitrector cutter, we found that there was an underlying cataract which was present, and so this cataract surgery was done. This was fortunately a child, so it was easy to aspirate out the cortical matter, and subsequently the pupil was enlarged in this case a little bit, so that the area of visualization was increased for the patient to see post-operatively, as the corneal opacity was bisecting right in the middle. So when you have a case like this, a hard, very hard cataract with a corneal haze, dry eye patient, you have to expand your area of visualization. So you have to use nylon hooks. And again, this half is the one which is clear for you to do your surgical maneuvers, and the incision is here so that this half, in this half, all the surgery can be done as was shown previously. Now, sometimes you have to use the peripheral chops in the sense that you do an anterior capsulorhexis, and then the central part is not chopped because there's an area of haze here, but you chop the periphery and get, after doing those peripheral chops, you get the central disc, which can be addressed later, because first you are chopping in the area of visualization, and then in the center only a disc remains, which can then be dealt with. And as you put the intraocular lens, it will always become better because the refraction gets taken care of once you put the lens. Now again, this was a tattooed cornea with a corneal opacity done years ago. So you have adherence of iris over here. Again, you expand your area of visualization, do capsulorhexis. After doing capsulorhexis, the nuclear emulsification, irrigation aspiration is done, and notice how the glow gets better and better. And following this, the foldable intraocular lens is implanted, and this area of the pupil is also expanded so that the patient is able to see in the post-op period from the area of area which is relatively clear. And notice that after putting the lens, it becomes a lot more clearer. Some of the cases of Stevens-Johnson syndrome, such as this, you can't do corneal transplantation because they're high risk for corneal transplants. So you use nylon hooks, use temporal incision, use endoilluminator inside the anterior chamber, chop and visualize where you are chopping. And when you're putting the intraocular lens, you use the endoilluminator outside, and this is followed by the intraocular lens implantation, which is done in the bag. Sometimes you have to use a chandelier also, as was done in this case. So nylon hooks are being used. This is a post-penetrating keratoplasty case, and endoilluminator is also used. Both of them are used, and because of the total internal reflection, the visualization gets better, at least for you to do the surgery. And subsequently, the intraocular lens is then implanted after nuclear emulsification, irrigation, aspiration is done. You can see that there's an intact PC there. Sometimes in haze, you can't make out whether the PC is intact or not, but if you do have this intraoposterior microscope, it helps you to know that. These are some of the cases where were in fact of Stevens-Johnson. If you do grafts, they are bound to fail, but here we did manage to get good visual acuity. Yet another case where patient improved to 20/40, and here another one which also improved to 20/40. These are again two cases from the same study that we published in JCRS. Here it is 6/60, but then the patient is ambulatory from hand movements close to face, and this was bilateral. So again, something we can still achieve without having to do the grafts. I think IOCT flax has a important role to play in cases of corneal haze, because it will not cut the area where the haze is present, but still be able to cut the rest of the area. So you may not get a rexus which is complete, but incomplete. So all you have to do is fill in the blanks. So here it is not cut here, but manually this can be cut. There may be no chops in the area where you are trying to cut, but again, manually those areas can be dealt with. So for instance, here this chop is not there and the rexus here is not there, but this can be done manually, and so it kind of helps to fine-tune your surgery better. Then of course, if you have anterior opacity, then you have no choice but to replace the anterior part of the cornea, which is done with the microkeratome. So the anterior part of the lamella are replaced. The phacoemulsification is done as you would do routinely. And whenever it gets blurry, put that blob of viscoelastic. Because when you put that blob of viscoelastic for that split of a second, it will become clearer and also will get magnified. And subsequently, the graft is then put after putting the IOL and is sutured onto the host. Now, this was a case again in which we didn't actually plan cataract surgery, but as we were doing DALC, that is deep anterior lamellar keratoplasty, we realized there is a cataract there. So again, there were issues of compliance and follow-up. So we did the cataract surgery at the same sitting. Again, it is easy to do it, but some amount of stroma still should be remaining here because you can't do it with a bare Descemet's membrane because the Descemet's membrane will rupture. And like I said earlier, whenever it gets blurry, put that blob of viscoelastic. For that split of a second, it will magnify and the visualization would improve. After the surgery is done, the last bit of stroma on the Descemet's membrane is removed and the graft is then sutured in position. And again, this patient had a good visual acuity. Both cornea and cataract were addressed. This case was Fuchs dystrophy with cataract, referred for penetrating keratoplasty, in fact, and we did the epitheliorhexis followed by the descemetorhexis because both the epithelium and the Descemet's membrane were scarred in this, followed by the anterior capsulorhexis, which was done with the help of the forceps, and then subsequently nuclear emulsification, irrigation, aspiration, and then the posterior DSEC lenticule was taken, was intracamerally put, and the air bubble was injected. So this case did well without having to actually do a full thickness keratoplasty. Now this case is 7 to 8 years down the line and has a visual acuity of 20/30 and is still doing well. You can do a DMEC triple, and because Amar is here, I'll say PDEC triple also. In cases of Fuchs dystrophy with cataract, and you do get very good results whenever you do a physiological graft, which could be a PDEC or could be a DMEC. This is a little more advanced post tuck-in lamellar keratoplasty phacoemulsification, in which the rhexis is being done over here, irrigation hydromaneuvers are done, irrigation aspiration is done. So what I want to highlight is that in these cases you have to be a little careful. IOL was put and there was a split between the host and the donor, and so you have to address this before you leave this case by putting an air bubble or draining this fluid out, and sometimes it can get really tricky even for cornea surgeons like us. Now, this was again a complicated case. This was penetrating keratoplasty already done, which failed, following which a DSEC graft is there. So you can see that this is a graft-host junction of a full thickness graft, and this is the DSEC lenticule of the DSEC, and patient now has a cataract. So in this case, the trypan blue staining of the anterior capsule was done just as you would do routinely, followed by the nuclear emulsification, irrigation, aspiration. The graft is quite stuck. It's not moving as of now, but as the intraocular lens was put, the graft moved a little bit. And again, because we have IOCT, it was visible right on the table. And subsequently, before, you can see there's a gap here. So you have to address this by putting air bubble or by increasing the pressure so that the graft gets stuck to the back of the cornea. So these are some of the problems which one can face. So this is the algorithm. So cataract surgery with corneal opacity, you may do phaco alone with or without optical iodectomy, or sometimes PTK with phaco would work. But if it is deeper, then depending upon where the depth is, you would have to combine this with endothelial keratoplasty or DALC or superficial anterior lamellar keratoplasty, depending upon where the lesion is. This is our review article which was published in JCRS on how to deal with phaco with coexisting corneal opacities. So to summarize, finding, seeing, creating and filling the gaps is important. Incision placement is important. Capsulorhexis may be eccentric. Copious hydro procedure should be done. Crater may be eccentric. You may need to do sphincterotomy or optical iodectomy in these cases. Retroillumination is the key. Good operating microscope is required. You require aids like nylon hook, trypan blue dye, dispersive OVD should be used, BSS plus should be used, low fluidic parameters do help, and I think most important is counseling. So for high-risk grafts, you can do phaco first and see how it goes. For those cases, good prognosis for grafts, you can combine them, but always counsel the patient that ambulatory visual acuity is what you are looking at, and not an eagle's eye vision of 6 by 5. Thank you very much for your kind attention.
Thank you very much, Namrata. Ladies and gentlemen,